books under the thing? No,
I think the height is nice.
the height is okay.
Lighting is nice too.
Yeah. Okay, great.
Okay, here we go. Good morning, and welcome to this week's episode of the Ask Dr. Murphy series. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you doing this morning?
Good morning. I'm doing fine.
Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest headlines, U.S. COVID statistics, and answering a viewer-submitted question through today, April 18th. We invite you to submit any questions you have down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Getting into the updated COVID statistics in the United States, average new hospitalizations per day are 1,045. In the same week in 2023, we saw 2,063. Average COVID deaths per day down to 68. The same week in 2023, we saw 207. New vaccine uptake staying steady. Adults 22.8%, 42.1% in those 65 plus, and just over 14% in children. Dr. Murphy, your reactions to those numbers?
Well, coming down as expected for COVID, which is great. We're well below 100 cases. This is persisting now over the last couple of weeks, and it's much less than it was last year. So things going in the right direction, and as we predicted. So we're in the middle of April, and this is when these respiratory infections start to really wind down. So all that's great. Vaccine uptake, bad as usual. But there are people out there that are taking it. They're protecting themselves, and that's great. And even 24% have taken the RSV vaccine, which I think is, considering that's a brand new vaccine, it's a good sign, because this can keep people out of the hospital and keep them alive.
Absolutely. And speaking of good signs in terms of, global work against pandemics and identifying them, there was some huge news from the federal government this week about a new partnership around pandemics. Can you tell us about that?
Yes, the current administration is promoting and actively supporting a huge effort that 50 other countries are expected to sign on, at least at the beginning, and maybe 100 at the end, to respond to the next pandemic. You have to prepare for these things. We were completely caught flat-footed with the last pandemic, and look what a disaster that was. And so the treaty hasn't been finalized, but it's going in that direction. There's a lot of support for this, and it will be a legally binding treaty that obliges countries to monitor pandemic threats and to share their scientific findings. It's just an organization structure so that we can figure out what's going on worldwide, because who knows where this thing is going to start next time. Is it going to be South Africa? Is it going to be Brazil? Is it going to be someplace in Asia? We don't know, but we have to keep looking. So the 50 countries have indicated that they want to do this, and this is great. This is going to cost us about $1.2 billion per year. Now, remember, the whole NIH budget is way higher than that. So, we've got, this is a drop in the bucket in terms of prevention. This can save multiple billions later on in the game. And think, since COVID came, what has been happening that's been affecting people worldwide? Ebola is back. Malaria hasn't gone away. Dengue is completely out of control in Latin America, especially Brazil. And Mpox, having outbreaks around the world, and most recently back in the DRC, Democratic Republic of the Congo. So, these infectious pandemics, especially the way people are traveling again, we've got to keep an eye on them. And this is just a step in the right direction. This is the prevention that we need, that we didn't have before.
Absolutely. And we will keep you updated on if more countries sign on to that. When it is made official, we'll be sure to let you know. But we do have a submitted question this week. Thank you for your submission. It is revolving around the measles outbreaks here in Chicago. The question is, what is being done to stop the measles outbreak, specifically in Chicago with the migrant shelters? Have there been COVID outbreaks in these settings as well? And just generally, why do we have so many measles cases this year?
Well, measles is highly, highly contagious. And there are 61 confirmed cases here in Chicago. There's 121 in the entire United States. So we've got basically half of the measles outbreak. So what has the Chicago Public Health Department done? They've done everything they're supposed to do, but there's only so much that you can do. They mandated 21-day quarantines. They led mass vaccination campaigns. They gave over 14,000 measles vaccines in just 1 month. That's a huge amount. And they've changed their intake procedure of migrants as they come into the country. And so that has kept the numbers down. It would be much worse if they weren't acting so proactively in this particular case. But there's only so much you can do with something that's as contagious as this. And, these numbers of cases is 17 times higher than the number of cases we expected in the last 3 years. So this is a big jump up, even though, we're still talking, 61 cases, 121 cases. Why do we care about that? We care about that because it's so contagious. Before the vaccines were developed, 48,000 people per year got hospitalized. 1,000 had encephalitis, brain inflammation, and there were 400 to 500 deaths per year from measles. So that was how it was, before the vaccine came out. And when the vaccine came out in the late 50s, the numbers plummeted. And by around the year 2000, there were no cases in the United States. And unfortunately, those numbers have gone up because the number of unvaccinated people has increased. You can blame it on people coming from other countries that aren't vaccinated, but that's not the whole story here. There's a lot of people in the United States that are not vaccinated because they don't want to take the vaccine. And they're going to be the drivers of these epidemics, and that can land people in the hospital and can even kill people. We're talking about mostly children. I remember in my internal medicine training days, I had a 60-year-old woman who was admitted to the hospital. She had been traveling in some exotic places in the tropics and came back really sick. We didn't know what she had. And, when you're in your training, you have kind of like these, you rank the patients, sickest patient on your service or whatever. She was the sickest patient on our service for weeks. And it was measles in an adult. How she managed to get measles being at her age, she should have been exposed already. But, it can be really a very, very serious disease.
And here in the US, the vaccine, which has been proven time and time and again to be safe and effective, is usually recommended for those 1 year or older. But I understand if there's international travel, you can get that vaccine younger.
Yeah. If you've got measles is a live vaccine, so it's recommended at 12 months of age and older. But because measles is so contagious, if you are considering traveling to a country where the measles vaccination rate is low, in other words, there's a lot of people at risk, you can actually give safely to children as low as 6 months. So if you have to travel and you have a 6 or 7, 8-month-old, they can get the measles vaccine, and they should, because they're probably going to get measles when they go over there. This is happening worldwide. This is not just the United States.
Absolutely. And as an example of one of those cases, several weeks ago, when we were looking into the much smaller outbreaks in Florida than seen here in Chicago, the first cases were from children, including an infant too young to be vaccinated, so under 12 months old, having traveled internationally. So if you are going to travel internationally with your kids and they're not yet vaccinated, please, please, please look into your options there.
Yep.
All righty. Our next story for today is about the safety data confirming the viability of co-administration of the influenza and RSV vaccine in those who are very high risk. Can you explain who the patients were and what the results were in the study?
Yeah. So a few weeks ago, we talked about the safety and efficacy of giving the COVID vaccine along with the flu vaccine, because of course it's going to be at the same time. And in that study, they showed that it was safe to do it. And as a matter of fact, not only was it safe, but the COVID vaccine actually worked better when it was given simultaneously with the flu vaccine. That was a huge finding. Okay, so now we're looking at the RSV vaccine and the flu vaccine. No one has looked at all three together, by the way, but two is the only thing that's been looked at. So this is 105 patients, very intensely studied. These are very high-risk patients, older patients with underlying heart disease, hypertension, all the like. This is a high-risk group. And they looked at them and found that they did quite well. It was very safe. Matter of fact, 65% of patients reported no symptoms at all. 2/3 of the people didn't have any symptoms. I had the RSV vaccine myself, alone, just a single dose. I didn't have any symptoms from that vaccine. I had a lot of symptoms from the flu vaccine. But anyway, it was safe. And this study showed that in these really high-risk patients, that it's safe to do this, even if you have underlying heart disease. There were no cardiac events, and nothing really has been reported. It's got a good safety profile, and it is something that you can offer patients if you're coming in for the RSV vaccine and you also need the flu vaccine. Now we're getting towards the end of the flu season, but it's still, if you haven't had the flu vaccine, there's still flu out there. You can take it with the RSV vaccine. I think that's just the big take-home point.
Mm-hmm. Absolutely. Now, one subject that you have touched on in some of our previous topics today is the dengue outbreak in Latin America and the need for more vaccines in the area. Can you give us a status update on that outbreak and also the status of these vaccines?
Dengue is like out of control. They've had 3.5 million cases in Latin America this year, which is typically in a whole year, they have 4.5, and we're only 3.5 months into the year. It's just been devastating. Only a quarter of cases of dengue have any symptoms at all. Most people are asymptomatic. But 5%, 1 out of 20 get really sick, and they ache and have chills, and the nickname for dengue is break bone fever. They're shaking so much they feel like they're actually going to break a bone. This year there's been over 1,000 deaths. Just myself have treated or have come in contact with 5 people who've gotten dengue. I mean, I'm just one practitioner here in Chicago and I have 5 dengue cases. It's like very unusual. All of them very sick. And one of the children of one of the families, everyone in the family got infected, ended up in the hospital. Now, everybody has done well and survived. The kid is out of the hospital and stuff like that, but it's a very serious disease. So no treatment is available yet, but there's 3 vaccines. One of them is the original one is a 2-shot deal. That's unfortunately the way it's made is very expensive, so that's not going to really help too much. The The second one is made by Takeda Pharmaceuticals. And they are having trouble ramping up the dosing, and they only could give Brazil 3.3 million doses, and they have 220 million citizens. So, I mean, that's a drop in the bucket. So anyway, a third vaccine is being developed, and this was reported in the New England Journal of Medicine, which is our top medical journal here in the United States and one of the top in the world. And they reported on the findings of a new vaccine that's made in Brazil. And it showed that the 2-year efficacy rate was about 80%. And in people who had previously had dengue, so they have a little bit of protection, it was approximately 90%. And so that's very powerful information that that vaccine works and is safe. And it's the Brazilian vaccine is going to be distributed in Brazil shortly, and Merck is going to distribute outside of Brazil or Latin America. I'm not sure exactly how they're breaking it down, but they've already calculated in Brazil that just the clinical expenses related to treating people with dengue is over $1 billion a year. So it's a devastating disease that deserves some attention, and looks like we're moving forward with ways to prevent it.
Absolutely. And hopefully dengue will become more part of the public consciousness, especially as people from all over the world are traveling to areas where it's very prevalent. It's something you have to be aware of.
Well, and we've had de novo dengue here in the United States. You know, as the climate changes, the climate gets warmer, those mosquitoes get further and further north. There was a case in Southern California. There's been cases in Florida. You know, it can happen here.
Absolutely. We will keep our eyes on that and keep you updated, of course. But our final story today is on a topic we've been talking about a lot lately. It's the avian flu, and specifically the most recent human case where a man in Texas acquired avian flu from a sick dairy cow. The CDC has done some viral sequencing on some of those samples, and can you tell us what they found?
Yeah, so this is goes back actually to our first story, setting up this network where we're going to sequence all these causative pathogens, we call them, the viruses and bacteria that cause these epidemics, to find out what's going on. So what they've done is in the avian flu samples from patients, found a mutation that is associated with what they call viral adaptation. In other words, the virus may become, it's associated with more easy transmission. So this is concerning. Now, the good news is that this mutation that they found, which is called PB2E67K, and I don't expect anyone to remember those, but that by itself doesn't enable efficient human-to-human transition. Why are we worried about human-to-human transmission? Because the mortality rate for avian flu in humans is somewhere between 20 and 50%. All right, way, way, way higher than other flus. So no need to worry now, but it's something that really has to be followed closely, because if this does evolve, if we get another mutation that does make it easier to transmit, we're going to have to come up with something really quick to prevent the spread of that. Imagine something 10, 20 times more serious than COVID. That is a disaster. But there's companies now working on developing vaccines specifically for avian flu. And even with COVID, those vaccines were made in record time, have been very safe. From the first sequencing in January of 2020 to the vaccine being put on the market in December, nobody ever thought we could move that fast, but we can if we have to. So we're way ahead of the game with avian flu. There are companies that have already made prototype vaccines for this, so we're light years ahead. So if something bad does happen, we're in a lot better position for something worse than COVID to come along. So that's all good, but we've got to have that network out there to identify where this is happening. In the interim, you know, we've got the birds and the chickens and turkeys that get infected, you know, they have to be culled. So we've got to eliminate the infected animals, get them out of the system as quickly as possible, and any other species too. Cattle and other things also can get infected. But right now, we still think that it's the birds giving it to the cows and other animals. But we'll see. But this takes some very sophisticated epidemiology and tracking and training and testing. And but that's the best we can do right now.
Absolutely. And like our other subjects, we will continue to research these topics and make sure that we are sharing the most up-to-date research we can find on these topics. But on that note, thank you very much, Dr. Murphy, for your time and expertise, breaking down the statistics, the articles, and answering our viewer-submitted question from this week. It's much appreciated.
Well, thank you, Katie.
And thank you all for joining us for another episode of the Ask Dr. Murphy series. If you have any questions you would like answered by Dr. Murphy, please submit them down below or send them into any of our social medias linked in the description. Thank you for watching, and we'll see you next week.